I'm Tim Leahy, and today we're going to talk about pneumonia treatment. If you have a patient in your clinic whose symptoms suggest pneumonia, then the next step is to do a physical examination. And here you're looking for the asymmetrical signs that suggest pneumonia. Whispered practically, crackles, egophony. Importantly, these are typically asymmetrical because heart failure and some other pathology you might hear something about in the lungs, usually symmetrical. If the patient has nothing concerning on examination and they're a pretty healthy, not fragile person, not sick, that's not pneumonia and you're pretty much done. But if your symptoms and your examination both leave you with suspicion for pneumonia, then the next step is a chest x-ray. Very, very importantly, no chest x-ray, no pneumonia. What you see on the chest x-ray is going to hugely impact what you do next. If the patient has nothing concerning on the chest x-ray, it's normal, then that's probably bronchitis or some other thing that you can just treat with TLC. But if the chest x-ray is abnormal, now you're thinking about treating them for pneumonia, giving them antibiotics. And so you're seeing here that this is a process of elimination, so that at any point along the way you could decide this person, either by symptoms or examination or a chest x-ray, doesn't need the miracle of modern antibiotics. But if you can check off each of these boxes, then you sort of feel like it's worth it. And antibiotics, that we'll discuss in the next slide, are the answer for them. So you remember from the pneumonia diagnosis slides that we have these different categories of kinds of pneumonia: community-acquired, sick community-acquired, healthcare-associated, ventilator-acquired, and aspiration. Each has a different spectrum of bugs that cause them. I want to review this quickly. So community-acquired pneumonia, you think about strep pneumo, atypicals like mycoplasma, chlamydophila, legionella, and viruses being way more common than things like resistant gram-negative rods, staphylococcus, etc. But the sicker the patient is, if they're going straight to the ICU, maybe 5 or 10% of them are from staph, and the atypicals just don't typically make you that sick, with the exception of legionella in fragile people. If instead this is a floor hospitalized patient who then gets pneumonia after being in for heart failure or dialysis, then you worry about resistant gram-negative rods and staphylococcus more than you would in community-acquired. And in ventilator-acquired pneumonia, you just get more of that bad resistant junk. Especially aspiration pneumonia is caused by the same things that cause community-acquired pneumonia, plus anaerobes. Giving antibiotics and choosing antibiotics is a balancing act. On the one hand, there are clear benefits of antibiotics. They're miraculous. They make the people feel better. They can save lives. That makes you look like a rock star. So what's not to like about that? But there are clear risks as well. So you can get side effects, mild ones maybe like a rash or an upset stomach, some diarrhea. You can get real complications like a bad rash, or you could get C. diff diarrhea, for instance. Antibiotic resistance is a big deal. You don't often see it in the person in front of you, but it's the next person you have to worry about. That next person who has a resistant bug that you can't treat and who gets sick or dies. This makes the next generation mad, and the whole deal makes you look like a schmuck. So how do you balance this out? It's pretty simple. You only give the antibiotics when needed, and only give the antibiotics that people need. You don't want to give too big of a gun for somebody who's not that sick or not susceptible to having a resistant bug, because it's wasted and you really essentially only get those risks. So how do you do that in pneumonia? For mild community-acquired pneumonia, atypicals and strep pneumo are the major bacterial pathogens, and for them, azithromycin or perhaps a tetracycline antibiotic like doxycycline will work just great. You might miss some strep pneumo with this azithromycin, but that risk of that is pretty low. For somebody who's sick enough to get admitted to the hospital, then you would worry a little bit more about that resistance, and you give them ceftriaxone. This is much less likely to, sort of be eluded by that bug. You still want to give azithromycin, though, because the atypicals are not covered by cephalosporins. And as an alternate therapy, you could give a quinolone antibiotic, like one of these. These, however, we try to reserve them, partly because they're expensive, partly because they can have some side effects, but mostly because we use those against resistant organisms, and we don't want to lose them. What if the patient's really sick? They have community-acquired pneumonia, but they come into the ICU. Here you worry about the same bugs, but especially Staph aureus becomes newly common. And so whatever you were going to give above here, you'd add vancomycin. If the patient has healthcare-associated pneumonia, you don't worry about atypicals anymore. And so the azithromycin is no longer part of the regimen, but Staph aureus and gram-negatives are part of it. So, vancomycin and ceftriaxone would be reasonable. Maybe vancomycin and ampicillin sulbactam. There's more resistance when you get into the ICU, and so ventilator-acquired pneumonia, you worry about similar bugs, but just more resistant versions of them. So here you're going to pull out a big gun antibiotic, not only vancomycin, but piperacillin tazobactam or piperacillin ceftazidime. And you might even add a quinolone into that, or a substituted quinolone to sort of cover the same spectrum. Aspiration pneumonia is a little bit different in that it's like community-acquired pneumonia, but anaerobes newly are in the box. And so here you do whatever you did for community-acquired pneumonia, but then you would add an anaerobic covering drug like metronidazole or clindamycin. Sometimes you'll see people do things like augmentin, azithromycin. That would be another option. Very importantly, we've been talking about pneumonia treatment, but I want to make sure that you know that we can prevent pneumonia. Getting your yearly flu shot prevents secondary bacterial pneumonia, prevents influenza pneumonia. And people who, in whom it's indicated, pneumococcal vaccination clearly prevents pneumonia. HIV is a major driver of pneumonia around the world, and so, preventing and treating HIV prevents pneumonia. And the same thing is true of TB control and prevention. Now, a big question to consider is, let's say you've done all of the stuff I've described to you right, and it's not working. The patient is still having lots of fevers, they're getting worse in some way. What should you think about? Well, you should think about resistance, you should think about collections of infection, like an empyema, an abscess that you haven't drained. Metastatic infection, maybe that pneumonia has spread someplace else, a spinal osteomyelitis. Or maybe that's not pneumonia, maybe they have heart failure or a rheumatological condition or sarcoidosis, whatever it is. So what's the take-home message? Make the diagnosis by symptoms, exam, and chest x-ray. You got to have all of them to have pneumonia. Pick the right drug for the right bug and be a rock star and not a schmuck. Prevention. Don't forget about vaccines and HIV and TB therapy. And, if it's not working, use your brain and sort of think about empyema, the wrong diagnosis, is there drug resistance, something like that, some new piece of information that you need to do the patient right. But most of it has to do with this table. Figure out what kind of pneumonia they have, remember the epidemiology, and hook them up with just the right therapy. Thanks a lot.